Hello, my name is Syed, and today we will discuss hand infections. Infection of the hand is of devastating consequences, with reduced quality of life if not recognized early. So, early recognition and expeditious care is necessary. We will discuss infections specific to the hand, with bites and other injuries and specific pathogens. So, a quick word regarding the anatomy of the finger. Finger is composed of several different structures which need a thorough understanding. Peronechium is composed of nail beds surrounding skin and the bed itself. It is made of lateral skin folds at the side of the nail. These are structures involved in peronechial infections. Hyponechium is skin distal to the nail, so it is the skin at the fingertip. Aponechium is skin fold dorsal and proximal to the nail fold. Nail bed has several important structures which need to be recognized. Lamina is white, crescent-shaped area of the proximal nail. Nail bed by itself consists of two parts. It is sterile matrix and a germinal matrix. Germinal matrix is proximal to the nail bed and is responsible for the nail growth. Pulp of the nail is constituent of small loculated compartments of fat that are separated with fibrous septa. They connect to the distal dermis, distal phalanx. This stabilizes the fingertip. This has importance in spinal infections. Regarding the finger infections, one of the most common is peronechium. Peronechium by itself can be divided into two types, acute or chronic. Acute infections are after minor trauma, presented with pain, erythema, swelling, and tenderness, which can be localized to peronechium or the epinecium. Common pathogen is Staph aureus. Diabetic could have polymicrobial infections. Treatment is with warm soaks and antibiotic. Drainage is indicated if abscess or collection is suspected. Regarding the chronic infections, they present in non-urgent situation and present after a prolonged exposure to the water or chemicals. They can also occur with immunocompromised case patients. Common pathogen is fungal, especially Candida albicans, involve more than 80% of the cases. In prolonged duration, nail bed hypertrophy is also possible, especially in diabetic cases. Treatment is the same, and local antifungal therapy can be instituted. Regarding the phelon is basically top space infection. Small compartments are there, so there is severe pain. Minor trauma is a predisposing factor, with bacteria inoculated into closed tight spaces. Staph aureus is the most common pathogen as well. Treatment is incisional drainage and antibiotics. Incision is mid-lateral, distal to the interphalangeal joint crease, on the ulnar side for second, third, and fourth finger. And for the small finger, it is towards the radial side. Breaking up all septas is important for decompression. Remember to take culture and sensitivity in these cases. Regarding the deep spaces, there are three spaces in the hand: thinner, mid-palmar, and hypothenor. Thinner space is deep to flexor tendon and superficial to adductor pollicis, and it is basically a bursal space. Hypothenor space lies palmar to the fifth metacarpal. Mid-palmar space is central space and is separated by facial septum from the other two spaces. Infection presents with pain and swelling at the palm. History of penetrating trauma or blunt trauma is a common predisposing factor in history. If swelling is present in the web space region, this is called collar button abscess. Clinically, deep space infections will have pain and flex posture of the digits. Any patient with penetrating trauma, always you should do an X-ray to rule out foreign body. Standard care recommend urgent decompression with antibiotics. Culture-specific antibiotic is mandatory. Do not give antibiotic in emergency settings, which can cause false negative results during the culture sensitive. Collar button abscess may need roller as well as dorsal incisions. Regarding the flexor tendon sheath infections, it is an orthopedic emergency. Flexor tenosynovitis, to remember, is an infection of the flexor tendon sheath. Direct penetrating trauma is a predisposing factor, and adjacent structures can also cause infection of the flexor tendon sheath. Regarding the flexor tendon anatomy, flexor tendon's sheath has a pulley system. Pulley systems avoid bow straining. For the fingers, A2 and A4 pulley is important. For the thumb, oblique pulley is important. E1 is a pulley structure which is released during trigger treatment for the trigger finger. The flexor tendon is covered with a sheath. The flexor tendon sheath of the index and the middle and the ring finger runs from the distal interphalangeal joint to just proximal to the E1 pulley. The sheath of the thumb, which is covering flexor pollicis longus tendon, runs from interphalangeal joint and runs and attached proximally to the bursa in the hand and the wrist. The sheath of the small fingers run from the distal interphalangeal joint of the small finger to the other side bursa, a sided bursa in the hand and the wrist. Remember that these ulnar and radial bursa do connect in some population. Due to this connection, this can cause infection to travel to involve the opposite side, causing a horseshoe abscess. Regarding the clinical presentation of flexor tenosynovitis, pain over the palmar aspect of the digit, affected digit, is the important finding. To remember is to remember the canaveral sign. There are 4 canaveral signs. Number 1, fusiform swelling of the digit. Number 2, holding digit in flex posture. Number 3, tenderness of the flexor sheath. Number 4, pain with passive extension. Commonest is number 1, which is fusiform swelling of digit, which is present in more than 90% of the cases. Early treatment can be of empirical antibiotics, and close monitoring is mandatory. These patients are for admission for 24 hours. If no improvement, would need irrigation and debridement. Most would need debridement, and common pathogen is Staph aureus. There are 2 different types of techniques for treatment of surgical treatment of flexor tenosynovitis. First is open approach. These are mid-axial or donor style incisions, and flexor sheath is opened up and thorough debridement is done. Important in this case is to avoid inadvertent damage to the pulley structures. The second, which is represented in the picture, is a close technique where 2 incisions. The first incision is at the E1 pulley and the other is at the E5 pulley. A catheter is inserted and irrigation system is used to have a thorough wash. Remember, this close treatment is always done in early diagnosed patients. Complications like stiffness of the affected digit is quite common, and early range of motion is important to avoid stiffness. Regarding the bites, cat and dog bites can cause infection plus damage to the soft tissues. The tooth basically penetrates to a tight space compartment. Once the extension of the fingers is done or the hand, the compartments are closed. Thus, the entire bacteria in the region with less blood supply inoculate and bacteria starts growing. Commonest for the cat and dog bite is Pasteurella multisida. Generally, however, they can be polymicrobial infections. Treatment is eradication of the wound with antibiotic like amoxicillin with clavulanic acid or third generation cephalosporins. Remember to quote rabies prophylaxis and tetanus prophylaxis. Severe damage to the viol if severe damage to the violet, which is violating the joints, would always need admission and surgical intervention. Regarding the human bites, these are basically always need irrigation and debridement at the OR. And antibiotics are always tailored cultures to the culture-specific antibiotics. Remember that the most common pathogen in human bites is Staphylococcus viridans or Equidilla corrodans. A short quote on marine infections. Basically, marine workers are more prone to marine water-induced infections. This can be due to salty water or clear water. The commonest pathogen is Mycobacterium marinum and comes up with a delay after inoculation. These are present with nodules or ulcers. Long, this specific type of bacterium would need a long duration of culture period, and culture-specific antibiotics are recommended. Culture for Mycobacterium marinum is similar to MTB, that is Lewis and Janssen medium. Combination therapy is generally required, and anti-TB treatment may be indicated. Thank you.